Hi, semester six. So we are doing module four. This is four chapters, 18, 19, 21, and 22. So we have assessment of immune function, coordinating care for patients with immune disorders, and coordinating care for patients with MDROs, and coordinating care for patients with HIV. This slide presentation is only 51 slides. So hopefully we're talking about 2.5 hours. Okay. These are our objectives. We're going to be talking about the immune response, right? So this is a little diagram straight out of your book that just talks about how the immune cascade works, right? How everything responds. So it's nice and simple. So take a look at this. It's figure 18.1. All right, so anatomy of the immune system. So components of the immune system include, we have the lymphatic system, primary and secondary lymphoid organs, then we have the cells and the proteins related to the immune response, right? Lymphatic system consists of lymphatic vessels and collecting ducts. Primary lymphoid or central organs include thymus and bone marrow. Secondary lymphoid or peripheral organs include the spleen, lymph nodes, tonsils, adenoids, and Peyer's patch. The cells and proteins include leukocytes, which are our white blood cells, T and B lymphocytes, so T cells, B cells, and then we have the cells involved in the inflammatory response, antibodies, cytokines, which are signaling proteins. So signaling proteins are going to tell other proteins to do something, right? And then we have proteins involved in the complement system. And the complement system is that whole cascade. 18, and again, 18.1, table 18.1 has this all drawn out for you. It's super nice. Lymph nodes and lymphatic system. So fluid continually filters out of the blood and into the interstitial space, the majority of which is reabsorbed back into the bloodstream. The lymphatic system is a network of vessels that transports excess interstitial fluid that has not been reabsorbed. So this is lymph fluid back to the bloodstream, helping to maintain fluid balance. This system contains thousands of lymph nodes strategically located superficially and deep within, sorry, lost my place, deep within the tissues near the lymphatic vessels. The nodes are small glandular structures that house macrophages, lymphocytes, and monocytes that actively filter and phagocytize microorganisms and other invading particles from circulating lymphatic fluid. If you don't remember, phagocytosis is like Pac-Man, right? It just eats all the stuff. Um, the lymph fluid moves through the lymphatic vessels, eventually emptying into the lymphatic ducts, the right lymphatic or thoracic duct, and returning to the general circulation through the subclavian veins, right? So filters, right? Just like, the heart pumps the blood and all the things, the fluid circulates as well. This filtering process prevents unwanted substances from re-entering the bloodstream. The thymus is a soft organ located in the chest cavity near the heart. It starts off large in children and decreases in size into adulthood. It is the central lymphoid organ that produces thymosin, a hormone that stimulates T cell production. And don't forget, we need our T cells to fight off infection. And so think about this. The thymus makes thymosin, which stimulates T cell production, which fights off infection. The older we get, the smaller and less active the thymus becomes, right? Almost disappearing in old age. And so we always talk about why older people are at risk for infection. Well, think about this. We're not getting all the same thymosin from the thymus to stimulate that T cell production, and the T cell production is huge in fighting off infection. All right, so thymus, that is where T cell production takes place. All right, now we're going to talk about bone marrow. Within bone cavities resides bone marrow or myeloid tissue, consisting of red, which is active marrow, and yellow, inactive marrow. This is where B and T lymphocyte formation and differentiation of B cells and T cells occur. B cells, when we say differentiation, that just means that the cell is becoming something specific. Okay? They start out like, like stem cells, like something very general, and then they're sent somewhere and they become more specific. T cells migrate to the thymus to mature. So T cells and B cells start out in the bone marrow. T cells go off to the thymus to become effector T cells or helper T cells, cytotoxic T cells, whatever, and B cells stay in the bone marrow and mature. All right, so bone marrow is super important. Imagine if you get cancer of the bone marrow, right? Because that is where our T cells and B cells are being born. And those, we don't even have an immune system if we don't have T and B cells. So the bone marrow is super, super important. And anybody who has bone marrow dysfunction of any kind, this is going to interrupt, I'm burping banana, sorry, but it's going to interrupt that B and T cell production, okay? Which then, of course, puts us at even more risk for infection. The spleen. Approximately the size of a fist, the spleen is located in the left upper quadrant of the abdominal cavity. As a part of the lymphatic system, it serves as a blood filter. It is divided into compartments that contain red and white splenic pulp. The red pulp serves as the filtering site for old or damaged red blood cells. It can also store blood. The white pulp of lymphoid tissue houses lymphocytes and macrophages, filtering unwanted debris like a lymph node. Although it is a redundant organ in the immune system, if it is removed due to accident or disease, the patient may become immunocompromised, with high-risk patients requiring lifetime antibiotics. I will say the most time, the patients I see with a splenectomy are related to motor vehicle accidents, based on like where the steering wheel is located, and they end up with a splenectomy, like it ruptures or whatever. So it's possible. And then we're always worried about infections related to these guys. Tonsils, adenoids, and Peyer's patch. Additional lymphoid tissues such as the tonsils, adenoids, and Peyer's patch are located in close proximity to mucosal surfaces within the body and provide another means of protection against invading organisms. The tonsils are located between the palatine arches on either side of the pharynx, right? They're like standing guard. They want to trap stuff before it can get down any further into the respiratory system. So they trap against bacteria and viruses that are inhaled. Located at the nasopharyngeal border, the adenoids also defend against inhaled bacteria and viruses. Peyer's patches are lymphoid follicles located on the mucosa of the small intestine. They are known as intestinal immune sensors and defend against pathogens that gain entry into the intestinal tract. Isn't that crazy? So let's say an organism actually makes it past the tonsils, past the adenoids, through the GI, right? Gets to the intestines. Now we have the Peyer patch follicles waiting to catch it, right? Or if you have a motor vehicle accident and you have like an opening of some sort, a breach in the skin and into the internal organs, we have these Peyer patches. So we have checks and balances for immune response all throughout the body, which is totally cool. This is figure 18.2. This is the central and peripheral organs of the immune system. So just a nice little diagram that shows you where everything's located. It's kind of cool. And it shows where all of our lymph nodes are, right? So when we talk about like spread of infection, we often talk about checking the closest lymph nodes to the site of infection, because if the infection itself has spread, those lymph nodes can be inflamed, right? So lymph nodes are definitely something we palpate, because you can feel whether or not they're swollen or what's going on with those. This is about assessment of the immune system, okay? So obtaining a comprehensive history and performing a thorough physical exam will assist the nurse in assessing a patient's immune function. Laboratory and other diagnostic tests are also helpful in the assessment of immune function. Pertinent information to obtain from the patient or significant other includes age, current meds, allergies, and the current problem. Medications that have immune system side effects include antibiotics, anti-inflammatory and immunosuppressive agents, anti-metabolites, anti-neoplastic agents, and thyroid suppressive therapy. The medical and surgical history is also important to obtain in addition to the family and social history because some immunological problems are genetic or chemically induced. Also included should be nutritional status, infection history, prior immunizations, chronic illnesses, autoimmune disorders, and cancers. Nutritional status is important to assess because suboptimal nutrition can negatively affect the immune system. For our physical assessment, this is going to include all of the vitals, inspection of the skin and mucous membranes, palpation of lymph nodes, exam of the neurological, respiratory, cardiovascular, GI, GU, and musculoskeletal systems, right? So full on head to toe. In a patient with immune dysfunction, the normal inflammatory responses may be blunted and subtle changes may be present. So we're going to want to look for signs of hypothermia or hyperthermia. In immunosuppressed people, instead of spiking a fever, the body will actually go hypothermic, okay? We're going to want to look for enlarged lymph nodes or edema, inspection of changes in skin color and skin integrity, rashes, dermatitis type lesions, hematomas, petechiae. Petechiae is those little tiny like pinprick red bumps. Purpura, all of that's equally important. We're going to want to look at changes in level of consciousness, cognition, gait, vision, hearing, changes in respiratory system. Maybe they're tachy, maybe they're retracting or coughing. Do they have nasal flaring, right? We're going to do a urine analysis. So we're going to look at sediment, odor, and blood. Stool sample, same deal. And if they have diarrhea or, what are their bowel movements? Diagnostics, we're going to have blood tests, skin tests, bone marrow aspiration and biopsy possibly, radiology, so X-ray, MRI, CT, just depending upon what's going on. Immune deficiencies that may occur can be primary due to aberrant development of immune cells or tissues, or secondary due to outside interference of the normal immune system. The disorders that follow may be due to infection, autoimmunity, hypersensitivity, or gammopathies. Gammopathies are caused by abnormal protein produced by plasma cells. Okay, you don't have to memorize that, just put it in your brain that it exists. Tests that we may use to evaluate immune disorders. So really we're looking to identify antibody deficiencies like T lymphocyte and neutrophil defects, complement abnormalities. What's going on with the immune system from a lab perspective. This is just a list of what we expect in a social history. Don't forget, when we talk social history, we're talking alcohol, drugs, smoking, lifestyle factors, travel, employment history, and environmental exposures. This is a safety alert just related to nutritional status. Nutritional status is really important when we're talking immunity, right? And one of the things, we always talk about with older people is they tend to be a little on the malnourished side and the dehydrated side. So this is definitely something we're going to want to consider when dealing with older people. A lot of people, they'll get like protein drinks on their tray if they're in the hospital. And that's just to help boost that nutritional status. So take a look at this safety alert. This is the aging immune system. This is also straight from the book, just a nice little diagram of expected findings, okay? Primary immune dysfunction. So the immune system protects against microorganisms through three lines of defense: mechanical barriers, inflammation, and acquired or adaptive immunity. So basically we have like the skin, then if it gets through the skin, the body tries to flush it out with inflammation. And then if it's something more serious, if we don't flush it out with inflammation, and that antigen stays in there, antigen's just something the body responds to, then the body uses an acquired or an adaptive immune response to throw all the cells at it and try to get it out. First line barriers and the inflammatory response are part of innate immunity. So innate, we're born that way, right? That reacts to an initial exposure to an antigen or microbe in a rapid, non-specific fashion. So we're born this way, so we don't necessarily know what we're going to come in contact with. So these are non-specific, okay? Subsequent exposure activates the adaptive response that specifically reacts to the microbe and creates lasting immune memory. So adaptive response. Now the body has identified what antigen we have, and it's going to make specific antibodies to that antigen, okay? Additionally, the immune system prevents the proliferation of cancer cells and initiates the healing of damaged tissue. Immune disorders may be due either to a deficiency or overactivity and may involve one or more components of the immune system. Deficiency can result in disease processes. Overreaction can result in reactions that may include anaphylaxis and autoimmune disorders, right? Our autoimmune disorders, they are nothing but our body responding inappropriately to something, right? Primary immune dysfunction occurs in a person born with an immune system that is deficient or limited in its ability to function. In this case, there is an intrinsic, so again, born this way, congenital or genetic cause. Most primary immune dysfunctions are inherited diseases, but some are the result of the interaction of predisposing genetic and environmental factors. These primary immunodeficiencies result from defects in T lymphocytes, B lymphocytes, natural killer cells, phagocytic cells, or the complement system. One classification of primary immune dysfunction involves B cell deficiencies. B cells are involved in producing a humoral immune response, which is the antibody response. An antibody or immunoglobulin is produced in response to a foreign substance known as an antigen. B cells mature into plasma cells that produce antibodies and immunoglobulins. So when we say immunoglobulins, that's like our IgG, IgA, IgM, and we'll talk more about those, okay? These antibodies and immunoglobulins bind to the invading organism, alter them, and make them more susceptible to phagocytosis. So they basically identify the antigen, and then the phagocytic cells, which are the Pac-Man cells, come along. They see that these cells have been identified, that they're bad, and they eat them. B cells are also part of a lifelong immunity that occurs from responding to infections and immunizations. B cell deficiencies involve a lack of differentiation of B cell precursors into mature B cells or a lack of differentiation of B cells into plasma cells. T lymphocytes include subtypes CD4 helpers and CD8 cytotoxic T cells. We talk about the CD4 a lot when we talk about HIV. They are responsible for the cell-mediated immune response that protects against fungal, protozoan, viral, and intracellular bacterial infections. They are also responsible for controlling malignant cell proliferation and coordination of the immune response. T cell deficiencies lead to infections and other problems that are more severe than B cell deficiencies. Immune dysfunction caused by T cell deficiencies result in recurrent infections. Secondary immune deficiencies are caused by a variety of factors, such as medication-induced immunosuppression, radiation, and surgery. The most common is medication-induced immunosuppression. Two of the most common reasons immunosuppressive therapy is prescribed are the treatment of autoimmune disorders and prevention of transplant rejection. Immunosuppression is also a side effect of chemotherapy in the treatment of cancer. Chemotherapy can lead to leukopenia, so we don't have enough white blood cells. This results in decreased cell-mediated and humoral responses. Remember that humoral refers to antibody responses. Another type of medication that suppresses the immune system is corticosteroids. Radiation therapy can also cause secondary immunodeficiency by destroying, dividing, and resting cells. Chemotherapeutic medications used to treat cancer are cytotoxic, which means they target rapidly dividing cancer cells. Cells of the immune system are naturally rapidly dividing, and so are inadvertent targets of chemotherapy. Cells such as white blood cells, including lymphocytes and phagocytes, are also destroyed by chemotherapy. So think about that. The thing about cancer cells that makes it such a problem is they proliferate so quickly, right? They reproduce really quick. But our immune system reproduces really quick too, because our immune system has to respond quickly to an antigen. So the problem with chemotherapy is it ends up killing off that good white blood cell reaction, immune system reaction, because those cells too are proliferating quickly, okay? So the result is a decrease in the number of circulating lymphocytes and phagocytes. Additionally, chemotherapy causes general immunosuppression because remaining lymphocytes are unable to release antibodies and lymphokines, which are substances that bind to receptors on target cells, facilitating a directed immune response. So the lymphokines go in and they bind to a cell that the body's like, this is a problem, and then the immune system comes in, sees that this has been identified, marked to kill, right? But that doesn't happen. So the problem with chemotherapy and stuff like that is it's not only killing off the cancer cells, but it's killing off the immune response. So that gives the opportunity for other things to get in, proliferate, and take over because the immune response is depleted. So immunosuppressive therapy, such as corticosteroid administration, is used to treat autoimmune disorders or prevent transplant rejection by specifically targeting the immune system, right? Remember, if we have an organ transplant, we don't want the body identifying it as a foreign antigen, right? We want it to accept it. So we have to blunt the immune response. The immunosuppressive medications interfere with cell-mediated immunity or the production of antibodies. Corticosteroids have anti-inflammatory effects in addition to immunosuppressive effects. The anti-inflammatory effects include stabilizing blood vessel membranes, decreasing permeability, and blocking the movements of neutrophils and monocytes. Immunosuppressive effects include decreased serum T cells because corticosteroids keep T cells in the bone marrow. This results in the suppression of cell-mediated immunity and lymphopenia, as well as a decrease in the inflammatory response. There is also decreased IgG production and decreased antibody to antigen binding. So antibody kills the antigen, right? And all of this just is depleted. So RN considerations related to immune disorders. So our assessments, vitals, right? We may expect increased temperature. We may expect hypothermia, if the person is immunosuppressed. They may be hypotensive and tachycardic related to infection. Let's see, signs of infection, WBCs with a differential. Differential tells us all our different WBCs, which then indicates to us what the body thinks it's fighting. Respiratory, obviously, if we have a pneumonia, maybe pain, GU, urine can be cloudy or smelly. Skin, obviously, we're going to look at rashes, lesions, that sort of thing. Actions, always think good hand hygiene, right? When we talk about spread of infection in facilities, it always comes back to hands of healthcare workers. So we can never underestimate using the hand gel effectively, washing your hands, all of that. Um, we're gonna treat the infection, give meds as ordered. We're going to think about if we have somebody who is immunosuppressed, we're going to consider the fact that the physician might be changing or taking them off their immunosuppressive therapy, possibly, right? Just something to think about. Teaching. We do not want our immunosuppressed people in large crowds. We don't want them, especially inside. Outside, a little bit of a different conversation, but inside, not good. Avoid people with illness. We don't want people with immunosuppression to change cat litter boxes because of toxoplasmosis. Also, pregnant women should not be changing cat litter boxes because of toxoplasmosis. We also want to avoid like turtles and reptiles as pets because they can carry salmonella. They recommend a low bacteria diet now. So that's like avoiding salads, raw fruit, vegetables, and undercooked meat, fish, and eggs. Also the fish in sushi because there can be parasites. So anything that has more potential to carry bacteria on it, they're supposed to avoid. And then the really big teaching is when to contact the physician, right? So temperature greater than 100 degrees Fahrenheit. If you have signs or symptoms of an upper respiratory infection, if your urine is cloudy, if you have a wound that is slow to heal, warm to touch, swollen, or has drainage, probably increased drainage is what I would go with. And then knowing the signs and symptoms of infection and then reporting them to the healthcare provider as early as possible. Like don't wait, right? Don't wait because an infection can really blow out of control quickly, shockingly quickly. In contrast to the immune deficiencies, when the immune system is initiated inappropriately or when it overreacts, autoimmunity and hypersensitivity disorders occur. Autoimmunity is when the body initiates an immune response against self. Antibodies are formed that respond to normal, healthy cells and tissue. The body fails to recognize these normal cells as self, which causes an immune reaction to occur against the perceived antigen, the healthy cell. So the body is identifying a healthy cell as an antigen, a bad guy, and attacking it. Okay? The cause of autoimmune diseases is still not completely known. Theories of causation include the inheritance of susceptible genes that may contribute to the failure of self-tolerance. Even with a genetic predisposition, some trigger is required for the initiation of autoreactivity. This may include an infectious agent such as a virus, meds, hormones, or environmental factors. Autoimmune disease are often classified as systemic or organ specific. So when we say systemic, it means it affects the whole body, or if it's like organ specific, like lupus can target the kidneys. And then we may not see, eventually you're going to see systemic response, but initially it could just be the kidneys, okay? A hypersensitivity reaction is when the immune response is overreactive to a foreign antigen. An antigen is a foreign protein that stimulates an immune response in a susceptible individual. Hypersensitivity reactions can be damaging to the body, may cause discomfort, and may also be fatal as in anaphylaxis. So when we talk hypersensitivity, there's a few that we really care about. Anaphylaxis is certainly one of them. Why? Because our person can die, okay? So there are several categories of hypersensitivity reactions. They are divided into five types. So we have type 1, type 2, type 3, type 4, type 5. You can find these on table 19.4. These types are based on the specific mechanisms and mediators that are involved in the process, the source of the antigen, and the length of time for the reaction to occur. This chapter discusses all of these hypersensitivity reactions, but focuses on type 1 and type 4. So these hypersensitivity reactions, like some are immediate, some are delayed. So that's when they're talking about time, that's what that's related to. Hypersensitivity reactions and autoimmunity overlap. Many autoimmune diseases have hypersensitivity as part of their pathogenesis. Graves' disease is an autoimmune disorder that is a result of a type 5 hypersensitivity. Lupus is the result of a type 3 hypersensitivity reaction. Goodpasture syndrome is an example of a type 2 hypersensitivity. Similarly, most but not all hypersensitivity reactions are manifested in autoimmune disorders, but one that does not manifest as autoimmune is a type 1 hypersensitivity reaction, a typical allergic reaction. So all that's saying, all the other ones have an autoimmune component to them, whereas type 1 hypersensitivity reaction, type 1, allergic reaction. But it's still scary because, again, anaphylaxis. So type 1 hypersensitivity reaction is a rapid or immediate allergic reaction. There can be a local atopic reaction, so like your skin, right? Or a systemic reaction. The most common is allergic rhinitis, also called seasonal allergies or hay fever, which is considered a local reaction. The most severe form is anaphylaxis. Let's see. Don't forget that anaphylaxis is a systemic reaction, right? Because it's involving a lot of things, okay? Whereas if I'm sneezing, if I have rhinitis, that's just my nose, right? That's just a nose problem for now. The primary mediator of type 1 hypersensitivity reactions is immunoglobulin E. I always remember this because immunoglobulin E is what's involved with your allergies. Are you ready? I'm sneezing here, okay? Chew! All right? Chew! Immunoglobulin E. You're sneezing. You have allergies. The IgE antibodies attach to mast cells. By the way, you're welcome. The next time the patient is exposed to that specific allergen, it binds to the IgE antibodies attached to the mast cells. This causes the mast cell to degranulate, releasing histamine and other chemicals such as leukotrienes and prostaglandins that cause smooth muscle contraction, vasodilation, increased vascular permeability, bronchoconstriction, and edema. So in doing this, all of the things that we associate with an allergic reaction, it's because of the release of these things. And they're supposed to be helpful. But unfortunately, if it goes wrong and the body overreacts, we can end up with anaphylaxis and you can die. So in an extreme anaphylactic allergy reaction, there is a severe and rapid onset of symptoms. These include bronchospasm, extreme dyspnea, shortness of breath, and wheezing. The patient may have hoarseness and stridor. Remember, stridor is related to the fact that this all is narrowing. Everything is narrowing. So that squeaky sound is like it's squeaking through that narrowed airway. Severe or untreated reactions result in anaphylactic shock with hypotension and tachycardia due to the vasodilation and capillary leak. So no good. This is evidence-based practice related to treatment of anaphylaxis. This is straight out of your book. Definitely take a look. RN considerations related to hypersensitivity type 1 reactions. So allergies and anaphylaxis. So first thing we want to do with our assessment is it a local reaction or systemic? And if it's systemic, we're a little bit worried about anaphylaxis, okay? We're also going to want to assess for anxiety or confusion, positioning, right? Are they sitting like they can't breathe, or do they look, pretty okay? Are they trying to catch their breath? Do we have facial edema or cyanosis? Facial edema, we have swelling of the face. We worry about that airway getting closed off. If we have cyanosis, that obviously is a sign of hypoxic something, right? And we worry about that. So that is going to indicate to us whether or not it is a local or systemic reaction. We're obviously going to monitor for all the vitals. Because of bronchoconstriction produced by the histamine release, respiratory rate may be increased. So they may be kind of panting, right? We may have wheezing, dyspnea, chest tightness. Again, stridor, watch out for that. Our SpO2 may be lower than we like. Blood pressure, they may go hypotensive because of vasodilation and capillary leak. They could be tachycardic. General assessment. So remember, we're going to have histamine release, right? So histamine release, your histamine causes everything to run and everything to itch. So they could have a rash, they could have watery red eyes, runny nose, sneezing, angioedema. We're going to want to look at their tongue. We want to make sure that their tongue is not swelling up. The patient may complain of feeling faint and diaphoretic. And they could have GI response. So diarrhea, stomach cramps, abdominal pain. And this is because due to the histamine release, we're going to have increased acid in the stomach. And so that can cause all those GI, all those GI signs and symptoms. So actions. Let's say the offending agent, maybe they're allergic to cats and they come into the ED holding their cat, right? Get rid of the cat. So discontinue offending agent ASAP. Now, this is important. If the offending agent is in an IV infusion, we stop that med immediately. Change out the IV tubing and we hang some normal saline, okay? So even related to an allergy to meds, okay, that we could cause this hypersensitivity reaction. So we need to be aware of that. If the reaction is from a food or environmental trigger, remove if possible. Medication causing the allergic reaction needs to be stopped to prevent any further reaction, and tubing has to be changed to prevent any further medication being infused. If the trigger is not removed, it may cause an increased and continued reaction. In the hospital, if you have an IV reaction, and this is true for blood too, but we save the tubing. We want to save the tubing because we want to further identify all options. Like, was it the med? Was something in the tubing? What the heck happened here? Okay, so you always save your tubing. We're going to anticipate stat medication administration of probably IM epi if there's a severe reaction. Epi is the medication of choice to counteract anaphylactic shock by causing blood vessel constriction, raising blood pressure, and improving cardiac output through inotropic and conotropic activity. That's very pharm. It also acts as a beta-2 agonist to promote bronchial smooth muscle relaxation. We're going to give oxygen, right, if needed. We're going to elevate the head of the bed to help them breathe better. And this is also going to help with hypotension. All meds, we're going to administer all meds as ordered. Administer diphenhydramine, which is our Benadryl, right? Benadryl's huge. Let's see, administer steroids as ordered. All the things. Look through that list of medication, right? Also, don't forget, we're worried about anaphylaxis. So we want to have our code cart outside, okay? We are worried about that. So you kind of just park that code cart right outside the door, just have it there. We're not going to leave our patient alone, right? Let's see, teaching. Sorry, I'm reading, talking, thinking. All right, teaching. So obviously, you come to the ED, you have going an anaphylactic reaction because you super love cats, but the cats don't love you. get rid of cats, right? Our teaching is to avoid that trigger. Um, we also want to educate the patient regarding signs and symptoms of an initial reaction, like rash or itching, sneezing, and we don't want them to let it escalate. Um, let's see, they may decide to carry an EpiPen on them. So we need to talk to them about how to use that EpiPen, when to use that EpiPen, and in particular, if they use the EpiPen, they need to come seek medical advice. That's probably the biggest thing with the EpiPens, because people will think, oh, okay, I can breathe now. Epi is short acting. So guess what? You may be able to breathe right now, but that does not mean you're going to be able to breathe in 10 minutes. So you need to go seek medical help. Also, we talk about like a medical alert bracelet. Um, we're going to go over allergies with patients and caregivers, right? Maybe they just had a reaction to something they didn't know they were allergic to. So we need to make sure that we update that and do the appropriate teaching. Now we're moving on to type 2. So this is an antibody mediated hypersensitivity reaction. So complement an antibody receptor, and antibody mediated cellular dysfunction. Okay, so this is when we get into blood. This is a safety alert related to blood transfusions and hemolytic transfusion reactions. So you probably already know from fundamentals, like certain blood types can only receive certain blood types, right? Now, how this really affects us as a nurse is not only verifying that when we get blood for a patient, that we verify that it's appropriate, but also then we need to, when we hang blood, there's a whole process to it. It's verifying, it's a two-person verification. We stay with the person. Most reactions happen within the first 15 minutes, so we stay with the person during the first 15 minutes. If something happens, we immediately stop that blood reaction. Now, stuff like itching, not uncommon. So you will see sometimes that they will order Benadryl to be given with a blood transfusion. And that is just to negate any of those little reactions. But again, we are still looking for a full-blown anaphylactic sort of reaction. But if you are ever nervous about what's going on with your person, stop that blood transfusion. I can tell you in my experience that people just say, oh, I don't feel good. They kind of get a flu-like response. Okay, so like this safety alert talks about chills, fever, pain, and a heat sensation at the transfusion site. The person may get a rash. So anything, if you're not comfortable with it, you stop that transfusion. And then you're gonna follow your hospital policy, but you will hang on to the tubing, you'll hang on to the blood. All of that goes back to the lab. Chances are your policy will tell you to hang some normal saline. You'll notify the physician, and you'll continue to monitor your person. These are compatible blood types and antigens. Okay, this is table 19.7. This is the blood transfusion reaction, RN actions. This is actually from ATI, okay? So this talks about stopping the transfusion, remove the blood tubing from the IV access, do not infuse any further blood into the system. You start an IV with normal saline. We monitor vitals and fluid status, and we send the bag and the tubing back to the lab for testing, okay? This will also, again, be dictated by your hospital policy. This is type 3 hypersensitivities. These immune complex allergic disorders are mediated by the formation of antigen-antibody complexes. So they're kind of like type 1s, but we also have an autoimmune aspect to these. So these can be systemic and local. This may be like lupus, RA, serum sickness. So there's a local immune reaction, and then you end up with a systemic reaction. So this involves the formation of an antigen-antibody immune complex. IgG is the immunoglobulin involved. These immune complexes are large molecules of antibody combined with antigen, and due to their size are difficult for the body to remove. So disease results when they are not removed but lodge in the tissues. So this IgG basically gets stuck, right? And then your body keeps responding. Type 4 is a delayed type hypersensitivity. So with type 3, sorry, going back to type 3, just remember that that's like lupus and RA, all right? So autoimmune. Type 4 delayed type hypersensitivity. This is like our poison ivy, our Mantoux test. You know, Mantoux test is the PPD or the skin test for tuberculosis, and a latex allergy. So type 4, what you really need to remember, it's a delayed reaction, okay? So like I get my PPD test and then we don't read it for like 48 to 72 hours after. I am waiting for, with the PPD in particular, I'm waiting to see if I have an antibody response. With poison ivy, you may come up against poison ivy and then in about like 24, 48 hours, you're all of a sudden covered in a rash, right? So latex allergies, latex can be immediate if you have a type 1 hypersensitivity, or it can be a delayed response. So just know that. People at risk for developing a latex allergy include healthcare workers because we are routinely exposed to latex, right? Also patients who have undergone multiple surgical procedures, especially patients with spina bifida, people with a previous history of atopic dermatitis or pre-existing hand dermatitis, and people who are female. Clinical manifestations of a local reaction typical of a positive TB test. This is kind of important. You know, we call it a wheel, right? Where you do the PPD, and then if you're positive, it's going to inflame. We call that a wheel. It's a wheel and a flare reaction. So when I first put the antigen, the tuberculin under the skin, I get a nice little raised area, a little bit of a puff. That's my wheel. And then if I am positive, I end up with an inflamed red reaction. Okay. Gets very edematous. I actually test positive to the PPD, and I decided to test myself about, I don't know, few years ago at work just to see, and oh my gosh, I was so purple and bruised for weeks. It's crazy. And with type 4, you still could have a systemic reaction like anaphylaxis. So anytime we have any of these reactions, latex is infamous for resulting in an anaphylactic shock. So we want to be aware. That's why we always ask people in the hospital if they have a latex allergy. Type 5 designation can be noted as a distinct subcategory, but is sometimes included in type 2s. This is an antibody-mediated cell dysfunction. You know, honestly, we don't care about type 5 too much. It's Graves' disease is our example, which is a form of hyperthyroidism. And then you can have some B cell stuff. For the most part, we really don't care about type 5. All right, multi-drug resistant organisms. So, infectious diseases have been plaguing the world for centuries. They are caused by pathogens, microorganisms that are capable of causing disease. For a pathogen to cause a disease, a susceptible host and a mode of transmission are required. A susceptible host usually has a weakened immune system or has had a breakdown in the body's defense mechanism. For an infection to be transmitted, a transport mechanism is required. Routes of transmission are contact, airborne, vehicle, and vector-borne. Contact transmission occurs when a person or object comes in contact with a pathogen. Airborne transmission occurs when pathogens are carried through the air. Vehicle transmission is an indirect mode of transmission that occurs when a disease-carrying agent touches a person's body or is ingested. Similarly, vector-borne transmission is also an indirect mode of transmission that occurs when a vector, an organism that transmits a pathogen, bites or infects a person. Think mosquito, okay? Contact transmission is the most common mode of transmission. Often in healthcare settings, patients acquire infectious diseases through indirect contact via the unclean hands of healthcare workers from contaminated equipment or from the contaminated environment. Infections that are acquired in the hospital and were not present on admission. So our book says that these are called nosocomial infections. Nosocomial, I can tell you, in the infectious prevention world is not used anymore. We say hospital acquired. So I doubt you guys are going to hear nosocomial used. It just means that it's an infection that you didn't have before, you acquired it in the hospital, but we say hospital acquired now, FYI. Multi-drug resistant organisms are common causes of hospital-acquired infections. MRSA, VRE, C. diff, Acinetobacter, and carbapenem-resistant Enterobacteriaceae are all examples of MDROs that cause hospital-acquired infections. MRSA infection is one of the leading causes of HAIs and is commonly associated with significant cost burden, morbidity, length of stay, and mortality. This involves both hospital-acquired infections and community-associated infections. They differ not only in antibiotic susceptibility and treatment, but also in their clinical features and molecular biology. So both of them are multi-resistant Staph aureus, right? But healthcare acquired, like if you were to look at it under a microscope, looks different than community acquired MRSA, and they do different things. Community acquired MRSA can be necrotizing bacteria, whereas hospital acquired MRSA is not, okay? So they do different things as well, and we treat them different. They have different antibiotics that they respond to. Staph aureus is a common asymptomatic pathogen and is considered normal bacterial flora of humans. So if we were to swab our skins right now, we'd probably be positive for staph. The 2019 CDC studies show that about 1 in 3 people carry Staph aureus bacteria in their nose, usually without any illness, and most will not develop serious MRSA infections. We call this being colonized, right? You're carrying a bacteria, but it's not doing anything bad, so you're colonized. Colonization can occur by touching the skin of another MRSA colonized person or touching a contaminated surface such as a countertop or door handle. If the skin is colonized, a MRSA infection can enter an open cut, scrape, or wound. Factors increasing risk for colonization include immunosuppression, prolonged hospitalizations, surgical wounds, IV sites, recent use of antibiotics, and being in close proximity to healthcare workers, patients, or family members who are MRSA colonized. Epidemiologically, HA MRSA and CA MRSA have different molecular characteristics, so they are susceptible to different antibiotics. Risk factors for hospital-acquired MRSA include hospitalization in the past 18 months, soft tissue infection on hospital admission, hospitalization in intensive care, and residing in a long-term care facility. These factors increase the risk of exposure through invasive procedures or medical devices, such as urinary catheters or IV lines, that create a portal for the entry, including hemodialysis or surgery. Also implicated are recent or long-term broad-spectrum antibiotic therapies, allowing bacteria to become resistant to a specific antibiotic. Other risk factors include people with an immature or weakened immune system, such as young children, older adults, or people with HIV or AIDS, as well as other comorbid conditions such as diabetes, cancer, COPD, congestive heart failure, and immunosuppression. MRSA is easily spread, especially in hospitals and healthcare settings, from patient to patient or from body part to body part on the unclean hands of healthcare personnel, or through improperly cleaned equipment. Thus, proper hand hygiene is essential when caring for patients with MRSA. Contamination was from side rails, beds, supply carts, nurses' sleeves, stethoscopes, and the pockets of nurses' uniforms. Risk factors for community-acquired MRSA include children younger than 2 years of age, athletes, IV drug users, men who have sex with men, military personnel, and persons living in correctional facilities or shelters, sharing razors, needles, or towels, and having contact with a MRSA-infected person. These risk factors are associated with close skin-to-skin contact, crowded living conditions, and poor hygiene. So treatment. The most commonly used medication for the treatment of infections caused by MRSA is vancomycin. This can be IV or PO. Now, the important thing with vancomycin is you need to draw troughs to find out the serum level of vanco. So serum levels of vancomycin must be monitored, especially in patients with renal failure. The trough level, so this is a blood sample that's drawn after a dose is given, but immediately before the next dose. So like if I have vanco, if I need to draw a trough and my vanco is due at 8 in the morning, I would draw my trough at like 7:30, okay? So troughs are monitored at least weekly to avoid toxic doses and maintain therapeutic levels. If trough levels are too high, vancomycin can cause nephrotoxicity as well as ototoxicity. We also might use IV daptomycin and IV tigecycline. These are pretty much used for complicated skin and soft tissue infections caused by MRSA. Patients receiving Dapto should be monitored for muscle pain and weakness and should have weekly creatinine phosphokinase, CPK, levels drawn to assess for rhabdo. Rhabdomyolysis is the breakdown of muscle tissue, and that like releases proteins into the blood that you normally wouldn't find, okay? Patients with renal insufficiency need to have more frequent CPK level monitoring. Tigecycline is in the glycylcycline antibiotic class that has extended spectrum activity against gram-positive, gram-negative, and anaerobic microorganisms. So all you need to know is tigecycline is effective against a lot. Tigecycline, though, may cause diarrhea, nausea, and vomiting. It also decreases the effectiveness of oral contraceptives, so we're going to want to let female patients know about this, right? We're also going to want to assess for rash. A lot of these antibiotics can cause this Stevens-Johnson syndrome. So it's a very rare toxic epidermal necrosis that causes the epidermis to separate from the dermis, typically because of a severe medication sensitivity. If administered prenatally or during early childhood, it may cause yellow-brown discoloration and softening of teeth and bones. So that tigecycline has quite a, or tigecycline, not tigercycline, has quite a bit of things that you're going to want to be aware of, as well as the Dapto, and then the vanco drawing the trough, and then ototoxic and nephrotoxic. Okay. This is VRE, so vanco-resistant enterococcus. So enterococci bacteria normally live in the GI tract and the female genitalia tract, and are also found in soil, water, and food. Risk factors for VRE are very similar to those for MRSA. All of these MDROs are going to have similar risk factors, right? So prolonged hospital stay, people with weakened immune system. This includes our ICU patients, transplant patients, cancer patients, anyone who has had prolonged exposure to antibiotics, especially maybe vanco and cephalosporins, people with recurrent UTIs, and anyone who has an invasive procedure or device. Don't forget that with invasive procedure and devices, think about our Foleys. We haven't necessarily breached the skin per se, but we have put this nice little plastic tubing up inside you that the bacteria is going to find super easy to attach to, and they actually form a biofilm on anything that we put in the body, which means they form a nice little community and they grow and proliferate and help each other, okay? So anytime we put a Foley, a PICC line, an IV, anything into somebody, we are increasing their risk of infection because we just provided a nice little home for this bacteria, okay? Enterococci commonly cause UTIs, peritonitis, which is an intra-abdominal and pelvic wound infection, and bacteremias. So clinical manifestations are going to be specific to what type of infection you have. Classic signs of UTI are back pain, pain on urination, and the sensation of needing to urinate and fever. Wound infections, they might be red, hot, maybe purulent drainage, and then bacteremias, you're going to see signs of sepsis. So tachycardia, hypotension, and fever. VRE infections are often difficult to treat and may require multiple antibiotics for treatment because most VRE isolates are resistant to penicillin and ampicillin. So we do our susceptibility testing, right, to find out what we should use. This is kind of interesting. This quinapristrin, dalfapristrin, Sinercid, given via IV, was the first antimicrobial agent available to treat VRE infections caused by E. faecium. VRE, the primary enterococcus bacteria that we see are E. faecium and E. faecalis. E. faecium is really the more prominent. So this new antibiotic is specific to E. faecium, and that's a big deal for hospital patients because people are not getting VRE out in the wild, right? You are getting VRE related to hospital stays and long-term facilities because people have brought VRE into that environment. So this new antibiotic is a streptogrammin and targets bacterial ribosomes, thereby inhibiting protein synthesis. This has some interesting directions on how to take this. So first dose of Sinercid may be given prior to blood culture results. So meaning we can go ahead and give it before we know for sure that we're dealing with VRE, okay? Dosages may need to be adjusted in patients with liver insufficiency. Length of therapy depends on the type of infection. Common side effects, joint pain, diarrhea, nausea, vomiting, and muscle pain. So generally though, two major treatments recommended for VRE are linezolid and Dapto. Let's see, off-label tigecycline can also be used, okay? And we talked about that earlier. This is a safety alert related to that new antibiotic. It talks about frequently monitoring for inflammation and pain at the infusion site. Increasing the volume of diluent may be required. A PICC placement is recommended if long-term use is required. All right, C. diff. Clostridioides difficile. Here we go. So, biggest risk factor for C. diff, antibiotic use, hands down, okay? Period. Increased use of antibiotics and the increased incidence of Staph aureus infections are implicated in the emergence of C. diff. Clostridioides difficile is the most common cause of antibiotic-associated diarrhea in the U.S. 4 to 15% of healthy individuals are colonized with C. diff, and 3 to 21% of patients on admission to hospitals are colonized with C. diff without showing symptoms of the disease. Colonization occurs in the large intestine. The risk of colonization increases steadily each day during hospitalization, secondary to the daily risk of exposure to C. diff spores in a healthcare setting. So don't forget that C. diff is a spore, right? It can exist like for months upon months on fomites. So inanimate objects in the hospital setting. So we are talking all the equipment, all the bedside tables, the curtains, all the things. There have been so many studies about how even with what we think is adequate cleaning, C. diff is everywhere in the hospital setting. It is terrifying. So the longer our person is in the hospital, and if the person has this crazy long hospital stay, chances are they're going to be on antibiotics at some point, which puts them at increased risk for acquiring C. diff. Okay. This is really interesting though. Newborns and children in the first year of life have some of the highest rates of colonization, but not infection. So most of us, what's interesting, they've done studies on that as well. Is that newborns are born colonized with C. diff. And then as they get older, that colonization, like the number of spores, basically decreases as they get older. But so C. diff is in us, it's around us, and if we're hanging out in a hospital, we are definitely going to come in contact with it. So risk factors for C. diff infection include the use of antimicrobials, yes, 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 particularly clindamycin, okay? Clindamycin, you may as well just start your person on C. diff prophylactic therapy, right? Just hang the Vanco in the Flagyl. Also, cephalosporins, aminoglycosides, penicillins, fluoroquinolones. So all of the antibiotics can cause C. diff. 60% of patients infected with C. diff have received antimicrobial therapy within the previous 3 months. Other risk factors include duration of hospitalization, immunocompromised conditions, chemo, NG tubes, because we're sucking the acid out of the stomach. So don't forget that acid in the stomach is like our second biggest resistance factor to infections, right? That acid just eats everything. Without that acid, we have bacteria that is able to proliferate that otherwise could not. Anytime you have a GI surgery, severe underlying illness, acid suppressing medications, right? Think about how, we assume in the hospital people are under more stress than usual. So we don't want them getting gastric ulcers, so we put them on PPIs, proton pump inhibitors, which inhibit the production of acid. But without that acid, we're like giving C. diff the green light to go ahead and just grow. So antibiotic use coupled with PPIs, you're just waiting for C. diff to happen. Let's see, the greater number of antimicrobials, the greater number of doses, and the greater the duration of administration, the higher the risk of a C. diff infection. So that makes sense. Longer you're on antibiotics, the more antibiotics you're on, the more those antibiotics are killing off good flora, so increasing your risk of C. diff. Okay. Trying to see what's important here. We're talking about killing off C. diff. In the environment, we need to use bleach pretty much. Don't forget that C. diff is transmitted from oral to fecal route. Okay, oral to fecal. So we touch the poop, we ingest the spores. When we are talking about cleaning off our equipment in the hospital, there is a dwell time or a kill time on our bleach wipes. So if our bleach wipes say that our dwell time is 2 minutes for C. diff, that means that the surface needs to be damp for 2 whole minutes to actually kill those C. diff spores. Also, we wash our hands when exiting a C. diff room with soap and water. We are not killing those C. diff spores. We are just washing them down the drain, which is totally, totally disgusting. Let's see. We always want to think about EVS when environmental services, when we have a positive C. diff room, right? Because we don't want to take a person who does not have C. diff, put them in that room, and then they end up with C. diff because cleaning was not appropriately done in the room. So you have to make sure that you change your curtains, that things are bleached, that your bed is adequately wiped down, all of that stuff, door handles, bathrooms, all of that, okay? C. diff produces We call it toxigenic C. diff, okay? Because there are strains of C. diff that do not produce toxins, and the toxins are what causes the GI signs and symptoms that we associate with the C. diff we see in the hospital. So C. diff in the hospital produces toxin A and toxin B. These are what causes those GI signs and symptoms. If somebody tests positive for C. diff and it's not producing toxin A and toxin B, they will not have those GI symptoms, okay? So what we look for is loose, watery stool, greater than 3 stools in 24 hours. It can be bloody and it can be mucousy. It is not pretty. The person may have abdominal pain and cramping. They can have a fever. And they might have like kind of flu-like symptoms, again, like not feeling very well, right? Before treatment for C. diff can begin, the suspected causative antibiotic must be stopped. Um, this says in about 20% of patients, C. diff infection will resolve within 2 to 3 days of discontinuing the antibiotic to which the patient was previously exposed. I am not familiar with not doing PO-Vanco for C. diff when it's identified, but maybe if somebody has been sent home and they're at home, maybe they will decide not to treat and see if it resolves on its own. Also, we do not want to use anti-peristaltic agents. So this is like loperamide. This is like our anti-diarrheals, right? We want the body to have diarrhea because as the body's having diarrhea, it's getting rid of that C. diff. It's getting rid of those toxins that were causing all the problems. So we don't want to stop that diarrhea process, even though it might be nicer for us, right? There can be life-threatening, um, let's see, progression to C. diff. You can end up with toxic megacolon. This is a life-threatening complication of inflammatory bowel disease that causes rapid dilation of the large intestine, which can result in septic shock, okay? Treatment, oral Vanco, so PO-Vanco, first-line agent for treatment of C. diff. It causes prompt symptom resolution, and there is a significantly lower risk of treatment failure. It is effective because it is not absorbed in the intestine and kills the bacteria at the site of the infection in the colon. When oral Vanco is not appropriate for the treatment of severe C. diff because of coexisting ileus or toxic megacolon, IV metronidazole is used. So that's Flagyl. Normally, when the hospital I was at, we would use PO Vanco coupled with IV Flagyl. Recurrence of C. diff infection is seen in 40 to 60% of cases. So that 4 weeks after therapy has been completed, reoccurrence can actually occur. Reoccurrence rate for patients treated with Flagyl is 20%, and reoccurrence rate with the Vanco, PO Vanco, is 18. Subsequent occurrences should be treated with Vanco using a tapered regimen. So they go ahead and put them back on the Vanco and just kind of taper that off. This is monoclonal antibody therapy as well has been approved. It's called Zinplava. This was approved in 2016. It is indicated in the reduction of recurrence of C. diff in patients who are receiving antibacterial medication treatment for C. diff infection and are at high risk for C. diff recurrence. This monoclonal antibody binds to the C. diff toxin B and neutralizes its effect. It is given as a single dose based on the patient's weight of 10 milligrams per kilogram and is administered by IV intermittent infusion over 60 minutes in a dedicated IV line. We do not give this a monoclonal antibody. We do not give this by IV push or bolus. So that's like the big part about this. And it does not replace antibacterial therapy. It just is supposed to help take down that toxin B. Probiotics, a lot of people always bring up like probiotics when we're talking C. diff. Honestly, the research does not support probiotic use. They haven't really shown to be effective. Once that stomach flora is, out of kilter, off kilter, it's really hard to get that back. One of the things they do use though is this fecal microbiota transplantation, and that's literally taking healthy poop with good flora and replacing it into a system, a body system. And this is for somebody who is like having crazy recurrent disease, right? That the C. diff just will not resolve. So the whole idea of this is to get that gut flora back to normal or at least healthy. So they do this, they can do it as a pill form. Um, let's see, look in here. They're talking about, your book talks about screening. They'll try to use family members because family members, especially if you live together, are going to have similar flora in your system because you are eating and being exposed to the same sort of thing. Um, let's see. That's pretty much it. They can also like literally transplant the poop. Okay. Oral capsule, I think would be the best option. It's not as, it doesn't have the same efficiency as literally transplanting the poop, but I feel like a capsule is going to sound a lot better. But there you go. So complications of C. diff. If I have diarrhea, I'm going to worry about hypovolemia, right? Dehydration. I'm going to worry about hypotension because I don't have enough volume. Renal insufficiency, electrolyte imbalances, paralytic ileus, intestinal obstruction, right? Peritonitis, which is inflammation of the peritoneum. Toxic megacolon, which we talked about. That is due to rapid dilation of the large intestine and can lead to sepsis. You also can have fulminant pseudomembranous colitis. So this is a severe form of inflammation of the colon. It can be caused by overgrowth of C. diff bacteria. So the problem here is we can go septic and die, right? We also want to think about skin breakdown. Our person is having nasty, wet poop, right? We are really, really worried about that skin breakdown. So you're going to want to use all the creams. You're going to want to do all the things. You may even consider a fecal management system. Now, the thing is with the fecal management system, that gets placed up into the rectum with a balloon inflated with water, much like we do with a Foley. After 10 days of use, you have lost a certain amount of sphincter control, period. So your person will always be slightly incontinent if you keep that fecal management system in place for longer than 10 days. Okay. If you don't know what a fecal management system is, YouTube it. Okay. It's disturbing. It'll never get out of your brain, but they are used in hospitals, so you're going to want to be aware of what they are. All right, we're talking about multi-drug resistant Acinetobacter. So it's a non-fermentative, so it's not producing any toxins, aerobic gram-negative coxobacillus that naturally inhabits water, soil, animals, and humans. It grows at varying temperatures and pH environments. It has been recovered from the skin, throat, and rectum of humans. It also colonizes the respiratory tract. This organism has the ability to survive for weeks to months on both dry and moist surfaces, which promotes transmission via contamination in hospital surfaces. The incidence of Acinetobacter infections is highest in ICUs, with complex patients in the ICU having the highest risk. Acinetobacter infections rarely occur outside of healthcare settings, and healthy people rarely get serious infections from this organism. However, the prevalence and resistance of Acinetobacter are also increasing in the community. Research has shown that increasingly resistant strains of Acinetobacter are being introduced into nursing homes and long-term care facilities, which is concerning because there are fewer resources for infection surveillance and prevention in these settings. Risk factors for MDR Acinetobacter infections and colonization include recent surgeries, central venous catheters, tracheostomy, and mechanical ventilation. Other risk factors include enteral feedings, bedridden status, exposure to antimicrobial agents, especially fluoroquinolines and carbapenems, prior colonization with MRSA, hemodialysis, malignancy, prior glucocorticoid therapy, and underlying severity of illness. Vascular catheters and the respiratory tract have been identified as the most frequent source of Acinetobacter bacteremia, so Acinetobacter in the blood. Other risk factors include prolonged hospitalization, ICU admission, prior hospitalizations, and nursing home residence. This organism is spread by direct or indirect contact, right? So patient to patient, or I touch the nightstand table and then go and touch another patient without doing hand hygiene, and so we have indirect transmission. Most common mode, as usual, unclean hands of healthcare workers, right? Transmission commonly occurs through contaminated skin, body fluids, equipment, or the environment. Multi-drug resistant Acinetobacter outbreaks are often traced back to common source contamination. So like one person, right? They can go back to patient 0. Respiratory care equipment, wound care procedures, humidifiers, and patient care items have been named as sources of contamination in recent outbreaks. Acinetobacter can infect or colonize many body sites. Typical sites of colonization and infection, we talked about this: respiratory tract, GI, blood, pleural fluid, peritoneum, urinary tract, surgical wounds, central nervous system, skin, and eyes. Clinical manifestations of Ebumani infections are VAP, so ventilator-associated pneumonia, and bloodstream infections. We also have the scary thing with Acinetobacter is carbapenem-resistant Acinetobacter. It has been rearing its ugly head. Probably about like 4 or 5 years ago, there was a massive outbreak of carbapenem-resistant Acinetobacter in the nursing homes, and that's bad because it's hard to treat. Like carbapenems are our biggest heavy-hitting antibiotic individually, and if something is carbapenem resistant, it's bad because we're kind of out of options, right? So this talks about, this is just more Ebumani treatment consideration. So typically we treat with carbapenems, right? So meropenem in particular. So if our Acinetobacter is becoming carbapenem resistant, we've just lost the main antibiotic to treat, right? Let's see. So carbapenems commonly cause nausea and headaches. They also, with carbapenems, you can get that Stevens-Johnson syndrome that we talked about. So you'd want to be aware of that. In 2020, the FDA approved a new antibiotic. It's a combo antibiotic. It's imipenem, cilastatum, and relebactam. It goes by Recarbrio, to treat a broad spectrum of bacteria, including Acinetobacter. Recarbrio is under the pharmacological class of carbapenem and beta-lactamase inhibitors. Talks about treatment here. Side effects are C. diff. Now, considering that this antibiotic just came out in 2020, a lot of people may not have had this antibiotic before. So when we ask them about reactions, they may not know if they've had a reaction to this because they may not have had this combination of antibiotics, right? So whenever you are using a new med on somebody, especially a new combo antibiotic, we want to make sure that we are standing by, monitoring for signs and symptoms of anaphylaxis. You're going to want to have your epi nearby, probably, you know, maybe your code card outside the room, just in case. You know, because the problem with anaphylaxis is you may have to intubate, and your code cart should have all your stuff. So you're going to want to make sure you have epi though. Again, if they have a reaction, you DC that IV right away. You collect that tubing, you follow hospital protocol, you notify the physician, but of course do not leave your patient alone. This is talking about Enterobacteriaceae. carbapenem resistance. Okay, so Enterobacteriaceae, that includes Klebsiella species and E. coli species. These are what we primarily see in the hospital related to carbapenem resistant Enterobacteriaceae. So normally found in the intestines, both of these, Klebsiella and E. coli, usually harmless, right? Now, the problem is they can spread outside of the intestines. Klebsiella, E. coli, UTIs, bloodstream infections, wounds, pneumonia, even meningitis, believe it or not. Infections with CRE are usually spread through direct contact with infected or colonized people, particularly contact with skin, wounds, or stool. Resistance of CRE to carbapenems is caused by two mechanisms. So the activity of beta-lactamase enzymes results in resistance to beta-lactam antibiotics. And so beta-lactamase is a mechanism of resistance. It actually breaks down the antibiotics. Carbapenem-resistant organisms also make carbapenemase, which is an enzyme that hydrolyzes carbapenem antibiotic. So again, it's breaking down the carbapenem antibiotic. So these organisms make proteins that break down the antibiotic. So the antibiotic is ineffective. Enterobacteriaceae can cause infections in people both in hospital and community setting. However, healthy people are not typically at risk. That's the other thing we talk about related to all of these infections. As a healthy person, you're not at risk. If all of your immune system is functioning, your skin's intact, all these things, you have good gut health and acid, you are not at risk for these things. It's people who are depleted, usually in more than one manner, that are at risk for these, okay? Risk factors similar for any other MDRO that we've talked about. Common comorbidities that put people at increased risk. Diabetes, heart disease, renal disease. Manifestations, gonna depend on where our infection is, right? This is kind of a scary statistic from our book, but the CDC reported that 50% of hospitalized patients who develop bloodstream infections from CRE bacteria die from them. Isn't that crazy? 50% if you end up with a CRE bacteremia. So treatment, like we talked about, options are limited because carbapenem's like our hardest hitting antibiotic. So it's going to depend on the susceptibility of the organism and where that organism is located. This is a safety alert from your book related to isolation precautions. Just talking about that we want isolation precautions used with our MDRO people, right? Also talks about hand hygiene, isolation gowns, tying the gown, use of gowns and gloves, and again, another one about hand hygiene. Our assessments for MDROs. So vitals. So we are expecting an infection here. So maybe a temperature. If they are immunocompromised, they might be hypothermic, right? Don't forget that part. Maybe increased heart rate. They could have hypotension related to being hypovolemic related to diarrhea, right? And even though C. diff is our only bacteria that we talked about that really causes diarrhea, but the response to a lot of antibiotics is diarrhea. So maybe we're treating with antibiotics, but they have diarrhea related to the vanco or whatever, right? Tachypnea can occur. Let's see. Of course, we're going to want to watch our O2. Pain, they could be in pain related to this, and that can affect vitals. Skin turgor and mucous membranes, urine output, all related to risk of hypovolemia. We're going to want to assess wound or surgical sites, right? What do those look like? Bowel movement frequency, consistency, skin integrity. Am I worried about further breakdown? We have lab tests to look at. If we're worried about liver or renal, we're going to be looking at those labs, right? So actions, hand hygiene times 10,000. We're going to put our person on isolation right away. If we are ever thinking that our person may have an enteric bug, so a gut bug, we are going to want to put them, we call it enteric precautions. That means we wash our hands on the way out of the room. Those are our gut bugs. So norovirus is included with C. diff as an enteric gut bug. We're going to give our antibiotics. It's okay to give fever reducers. Pain meds are okay. We're going to want to encourage hydration. Maybe that's an IV, maybe that's just making sure their pitcher is full. Mobilization, right? Usually hospitals will let you mobilize C. diff patients if they are no longer having active diarrhea, right? Now, this is all going to be based on your hospital policy though, so that is how you would find that out. Wound care, incontinence cleaning. If our person has diarrhea, or even if they're not incontinent, even if they are able to make it to the commode, right? We're still going to want to make sure that they have good cleaning down there because we're worried about skin breakdown and we're worried about further infection. Teaching, I can tell you from firsthand experience, you're going to have to teach that family the expectations related to contact isolation, right? And if it's an enteric bug, you're going to have to talk about washing your hands with soap and water on the way out. We have antibiotics, so taking antibiotics as prescribed, that's always going to be a teaching. Clinical manifestations of infection. What should we be worried about, right? When should we contact our physician? Also, a lot of these antibiotics, in particular tetracyclines, have sun sensitivity. So you're going to have to teach about avoiding the sun. And then, with all those antibiotics that we talked about, they do have different signs and symptoms of reaction, right? Now, normally a reaction is going to happen pretty quickly, okay? Now, your person may be taking their antibiotics for like 3 days and develop a rash. Concern, yeah, should they call? Sure. Diarrhea, kind of expected. But we want them to know when to contact the physician and related to what, okay? All right, now we are moving on to HIV. There's quite a few slides on this, just because there's a lot of considerations here. You don't have to memorize all of this. Keep in mind, as usual, we are worried about what to do and how to handle these situations as nurses, okay? But you have to have a general idea of the disease process so that you can speak to what's happening and actually offer or have a better understanding of how to offer therapeutic communication with some of these more difficult topics, right? So you kind of have to know a little bit at least what's going on, all right? So this is HIV, and we'll talk about the progression to AIDS. So like many chronic illnesses, HIV disease caused by the human immunodeficiency virus consists of several stages ranging from acute infection to death. In an HIV-infected individual who does not receive treatment, the length of time from infection to death is approximately 12 years. In resource-limited countries, the time from infection to death is approximately 5 years. Malnutrition, TB, and malaria are comorbidities that shorten the time the untreated patient survives. So think about the situation in Africa, right? With malaria and all of that, it's horrible. Currently, anyone infected with HIV, regardless of the stage of their disease, is considered to have an HIV infection. In adults, the illness is categorized into one of 3 stages based on the individual's CD4 lymphocyte count, right? So we talked about the CD4 cells really coming into play in the immune system. We see this in particular with HIV, okay? Because HIV, the virus, specifically attacks the immune system. It takes out those CD4s, okay? Let's see. Sorry, I get off on my tangents on the CD4 cells. All right. So one of three stages based on the individual CD4 lymphocyte count, CD4 percentage of total lymphocytes, or the presence or absence of certain infections commonly found in individuals with a compromised immune system, an AIDS defining condition. So there are diseases that specifically indicate that a person has progressed onto AIDS. During AIDS, you have like no immune system left, right? So you end up getting these crazy infections that normally people do not get, all right? Because at least some of our immune system is usually intact. With the AIDS patient, there is no immune system left to respond. If the person has an AIDS defining condition, that person is considered to have AIDS regardless of CD4 count. According to the WHO in 2020, approximately 37.7 million people were living with HIV worldwide. However, unlike many other infectious diseases, a vaccine to prevent the illness is not available, as the constant change in the structure of the virus makes the development of a vaccine challenging. So it keeps mutating is the problem. Until a vaccine is available, strategies to mitigate HIV-associated risk behaviors, e.g. condomless sex and IV drug use, should be encouraged. So our main strategy at this point is to reduce risky behaviors. Transmission. HIV is most commonly a sexually transmitted disease, although many individuals contract the disease via IV drug use. This mainly occurs through sharing injection equipment that may contain blood from an infected individual. Blood transfusions infect a minimal number of individuals. The CDC notes one reported case since 2002, and that's when we started screening, right? There's so many screening procedures in place now. It is such a minimal risk. Also, I want you to pay attention to this. A smaller number of people, 0.36%, 0.36% have acquired HIV through occupational exposure. So needle sticks, and that's us, right? So just know your risk of HIV transmission related to a needle stick is less than 1%. Believe it or not, Hep B is our biggest concern, but we talk about that at another point. Pregnant or breastfeeding persons, women infected with HIV can transmit the disease to their children. However, the risk of perinatal transmission is significantly reduced with access and adherence to antiretrovirals. Okay, so anytime we have a pregnancy consideration, you're going to want to make sure that you put that in your brain, all right? The immune system protects the body by recognizing and destroying infectious agents such as bacteria, viruses, and parasites, abnormal cells, or foreign objects. So this could be anything from splinters to transplanted organs, right? When an individual becomes infected with HIV, immune system functions are compromised, and the individual becomes more susceptible to various infections. There is chronic persistent destruction of infection-fighting cells. The CD4 cells by the replication of HIV. So as HIV replicates, it literally takes over the CD4s, okay? The CD4 cell is a T lymphocyte with CD4 receptors on the cell surface, also called a T helper cell. Typically, when stimulated by a recognized antigen from a virus-infected cell, the CD4 cell releases cytokines. This activated B lymphocyte and killer T lymphocytes to destroy the invading organism. HIV targets the CD4 cell. The infected individual manifests various stages of HIV disease over time. If the HIV infection is untreated, the individual eventually dies, usually from an opportunistic infection. So this is box 22.1 in your book. It lists some of the different opportunistic infections that people can get. And again, this is because they have no immune system left. One of the really weirdo ones is this pneumocystis pneumonia. It's also was called pneumocystis jirovecii. But it is this pneumonia that is specific to AIDS patients. You just don't see it anywhere else. So it's this pneumocystis pneumonia, PCP, or they may also call it pneumocystis jirovecii, but it's still called PCP, even if they're using pneumocystis jirovecii. Don't ask. They changed the name, kept PCP because people are comfortable with it. Okay. Notice that TB is on that list as well. And then in class, we're going to talk about Kaposi sarcoma. So cytomegalovirus is something you can see in respiratory patients, and CMV. You can also see it in UTIs and stuff. So CMV you can see in other places other than just related to your HIV people. This is about HIV to AIDS. Now, again, you don't have to memorize this, but you need to have it in your head, okay? So when a person is first infected with HIV, the virus causes an inflammatory reaction. So our inflammation reaction, white blood cells, macrophages, all sorts of fluids to the inoculation site. A virus particle attaches to specific receptors on the CD4 cell. CD4 receptors and co-receptors and enters the cell. Once inside the cell, once the HIV is in the cell, viral RNA is changed to viral DNA. Remember the whole reverse transcriptase thing? Using enzyme reverse transcriptase. The viral DNA is then integrated with the CD4 lymphocyte cellular DNA in the lymphocyte's nucleus. So the HIV gets into that CD4 cell and becomes part of the DNA. All right? So it takes over that cell. The HIV DNA is now in charge of cell reproduction and produces new viral proteins. The viral proteins are assembled and new HIV viruses are released to infect other CD4 lymphocytes. So it gets in there, it takes over the DNA of the CD4 cell, and then it releases more HIV virus to go out and infect more CD4 lymphocytes. Okay, so eventually you have this virus out there floating through the bloodstream, taking over CD4 sites, and each cell that it manages to take over, it is able to reproduce that much more HIV to go out and take over that many more CD4s. Okay, so you end up with a rapid increase in viral load. Okay, and viral load means how much HIV we have in the blood. This period is acute viral infection. So at this point, now think about this. We have this war going on inside of us that we don't even know. We have HIV trying to take over CD4s. Meanwhile, your immune system is still going to be trying to fight this. Okay, so anytime our immune system is trying to fight something, we end up with those flu-like symptoms. So low-grade fever, generalized aches and pains, swollen lymph nodes, just kind of a general feeling of illness, right? After several weeks, the person's immune system develops antibodies to HIV. Seroconversion occurs. So the interval when HIV antibodies are first produced and rise to detectable levels, and the person tests positive for HIV. So remember, when we're testing for antibodies, right? We're not testing to identify the virus. We're testing to identify antibodies to the virus. Did our immune system respond and make antibodies to this? When we do a tuberculin skin test, what causes inflammation if you're positive is the fact that you have antibodies to TB. So I give you a little tiny shot of tuberculin, right? And your antibodies respond. If you're positive, antibodies respond because you've been exposed to TB at some point or another and your body made antibodies. So when we test for HIV, we are testing to find out, has your body made antibodies to HIV? The immune system begins to exert control but cannot eliminate viral replication. So immune system fighting, but HIV still taking over CD4s, releasing more HIV, okay? As a result, so CD4 count gets to be about near normal, and the viral load drops to a set point level. The viral set point occurs when viral replication is still taking place, but during this phase, the immune system can destroy the virus in equal amounts as is being produced. So right now, our immune system, it's keeping it at bay, right? Not necessarily winning per se, but it's keeping it at bay. Over the years, the viral load slowly increases while the CD4 count slowly declines. As a result, untreated individuals lose approximately 50 to 100 CD4 cells per year, leading to symptomatic chronic infection, which may take as long as 10 years. As the HIV-infected individual's CD4 count falls, control over viral replication is slowly lost. The immune system becomes less able to fight off infections. Individuals develop nonspecific symptoms such as more frequent respiratory tract infections, skin problems, lymphadenopathy, which is just enlarged lymph nodes, and weight loss. The CD4 count falls more rapidly, and there is a rapid increase in viral replication. Once a person becomes symptomatic, the average time to develop AIDS is approximately 2 years. So AIDS, as the CD4 count continues to fall, the immune system is less and less able to fight off infections. As a result, infections can use the opportunity of a non-functioning immune system to infect the body, or the immune system loses the ability to control infections that are in a dormant phase, allowing the infection to become reactivated. An HIV-infected individual has AIDS when the CD4 count is less than 200 cells per microliter, or when diagnosed with one or more AIDS-defining illnesses. And don't forget, those AIDS-defining illnesses are those opportunistic infections we looked at. Commonly occurring AIDS-defining illnesses in the United States are pneumocystis carinii or Jirovecii pneumonia, Mycobacterium avium complex, MAC, toxoplasmosis, remember that's the one from the cat litter, right? Esophageal candidiasis, and recurrent bacterial pneumonia. Target organs for damage secondary to HIV are the renal, peripheral, central nervous, and cardiovascular systems. So if toxoplasmosis is a risk for our AIDS patients, do we want somebody with a declining immune system changing cat litter boxes like we talked about? No. Also, the whole thing with the reptiles, you know, the turtles, lizards, snakes, that sort of thing, risk of salmonella with that. So we would not want these guys to have reptiles either. This is just a short little box 22.2, of the progression through HIV to AIDS stages, okay? This is a picture of an AIDS patient. They get the muscle wasting that they encounter is just crazy. It's called cachexia. And no matter what type of nutrition we try to provide, when a person becomes cachexic, that you are not gaining back any of that muscle. And so AIDS patients just end up looking so gaunt. It is just so sad. It's such a sad progression. These are clinical manifestations of AIDS. And again, this is our person with no immune system left, right? The virus has taken over, it has won. These are all the clinical manifestations. And again, there is another picture of an AIDS patient. Now, this is important because these are clinical manifestations that indicate deterioration in HIV patients. So, HIV, they still have some immune system left, right? They may be on therapy. They may be doing meds, but we are always worried about what is going on with that immune system. So these are signs and symptoms that maybe in a normal person we may not be that worried about. But in a person with HIV, because we're always worried about that progressive deterioration, is HIV taking over more of those CD4s. So new cough, increased fatigue, temp greater than 102, night sweats, new onset headache, right? Normal thing. Visual blurring, recent change in mental status, watching those new skin lesions, new onset of diarrhea, and a weight loss greater than 10% of previously recorded weight. So this is not like you're trying to diet and lose weight, right? This is losing weight for no reason. So a weight loss greater than 10% of previously recorded weight. So all these things we want our person to be educated about. Um, this talks about when to screen, right? U.S. Preventative Services Task Force recommends annual screening for HIV infection in adolescents and adults ages 15 to 65. Younger adults or older adults who are potentially at increased risk should also screen. Frequency of screening, usually annually, but could be more frequently if the person engages in risky behaviors. So like sex work, substance abuse, or condomless sex. Um, let's see. Diagnostics and screening tests assess for antibodies to HIV. There are rapid tests, right? So they take 30 minutes or whatever to come back. They just identify HIV antibodies. So if you have a rapid screen come back positive, then you want to go to a lab and have the lab do like an ELISA, or if they do an ELISA, then and that comes back positive, they'll do a Western blot. Also, PCR is what is used to determine viral load. Okay, so just know that there is a rapid test. If rapid test comes back positive, then we're going to go and do further testing. Now remember, we want to repeat these tests. We repeat them in 3 to 6 months, because just because I have initial exposure, I don't get antibodies right away. That's a process. So I may test negative. So I do want to go for a retest if I really think I was potentially exposed. All right. Department of Health and Human Services. So this is about ART, antiretroviral therapy. And this is a big deal because this is allowing HIV positive people to continue a normal life. ART is huge. It's a breakthrough. So Department of Health and Human Services in 2017, recommendations for initiating antiretroviral therapy state that it should be recommended for all PLWH. This is people living with HIV, PLWH. Antiretrovirals interfere with the ability of HIV to reproduce itself. So 6 classes of meds are currently available in the US. Individuals are prescribed 2 or 3 meds from at least 2 different classes. In addition, most individuals can take a combination medication, 1 pill that contains 2 or 3 meds. So that really helps with compliance. Back in the day when ART first came out, it was literally like a handful of pills. And that can get there can be a lot of psychosocial considerations related to that, right? After a while, you may start to think, why am I doing this? I have to take these pills all the time, same time every day. They're ruling my life. Why do I want to live like this? Sort of thing. So the fact that ART has come out with single pills that incorporate multiple medications, that too is huge for HIV ART. Before the initiation of ART, we're going to want to check liver and kidney function, right? Significant physiological abnormalities influence the medication choice because medication metabolism occurs in the liver and kidneys. Once ART is begun, the CD4 count will increase, and the HIV viral load will decrease to non-detectable levels. This is generally achieved in 6 to 8 weeks. The CD4 counts and viral loads are followed at regular intervals as recommended in the DHHS guidelines. The viral load may be obtained every 6 months for stable patients and the CD4 count yearly. Medication adherence should be reviewed at each patient encounter. Patients should be supported to achieve 95% adherence to their ART regimen. One of the earliest signs of treatment failure is missing doses of medication or missing scheduled appointments. So for ART to be effective, it has to be taken same time, every day, all the pills, all the time. And it is for a lifetime, okay? So it is so important that we encourage 100% adherence, right? Um, because as soon as they stop the ART, you know, that HIV can start taking over CD4s again, and then you go right back into the whole downward spiral of getting to a point where you have no immune system left. So stressing the adherence to ART, making it available, encouraging adherence. All of this is so important. Um, but it can be challenging, right? Especially if we are talking with younger people who don't necessarily understand consequence yet. Maybe their brain is not there. Maybe, you know, they think, well, they're going to come out with something and I'm not going to progress to AIDS and it'll be fine. And believe it or not, this is stuff I have run into with patients. So it's very interesting, even though you may not think it's that big of a challenge to take pills at the same time every day, blah, blah, blah. It actually is for some people. So it's a big deal. Also, there's side effects to the medication, so we need to talk about that. And then, of course, you need to talk about viral load and, you know, who is your partner? Do you have a partner that you're normally with, or do you have multiple partners? What is happening with that? And are you still using safe sex? You know, there are different strains of HIV, so you still have to have, even if you have two people who are HIV positive, they may be positive with different strains, and so there's considerations related to that. This is a safety alert. This is just talking about sulfa allergies. Trimethoprim sulfamethoxazole is Bactrim. Okay, we typically use the word Bactrim versus trimethoprim sulfamethoxazole because Bactrim's way easier. But we always need to be aware of, as healthcare workers, that Bactrim's a sulfa antibiotic, and a lot of people are allergic to sulfa meds. So this just talks about that, okay? Vaccination considerations. As usual with someone who is autoimmune, we do not want live vaccines, right? We do not want live vaccines. That is true across the board for anybody having immune deficiency issues. So autoimmune, HIV, whatever it may be, anybody with a compromised immune system, no live vaccinations. Everything else, for the most part, is good. One of the only other considerations is a shingles shot recommended at age 50 for HIV positive people, as long as their CD4 count is greater than 200. So that's one of the only other considerations, okay? That's kind of specific to HIV. This talks about occupational exposure, what to do when we screen, use of post-exposure prophylaxis, PEP, right? Again, though, keep in mind your risk is less than 1% related to needle sticks, and that is how you would contract HIV if you contracted HIV. So less than 1%. But take a look at this safety alert. As healthcare people, we need to be aware of this. This is evidence-based practice for our PEP, pre-exposure prophylaxis. So this is kind of interesting. This is for people, maybe they are dating someone who, it's called PrEP, not PEP, I'm sorry. But this may be somebody who is dating somebody who is HIV positive, or somebody who, maybe they're engaging in risky behaviors. But this is PrEP is for HIV uninfected people. So it uses antiretroviral medications as an evidence-based way to prevent new infections among those at risk. So this is a proactive approach, and this is pretty groundbreaking, right? So take a look at this slide, okay? And know that PrEP is a proactive approach, pre-exposure. So as nurses, our assessment, our vitals, we're going to look for signs and symptoms of infection, right? We're also going to look at that weight. Remember, they may have a low-grade fever because the body, the immune system, is not releasing those pyrogens to cause a fever, right? So they may be hypothermic. We're going to want to look at respiratory. We're always worried about that pneumocystis jirovecii pneumonia, the PCP. So pneumocystis carinii, pneumocystis jirovecii, PCP pneumonia, right? So we're always going to be assessing respiratory status, weight trends, that loss of 10% or more from the last weigh-in, we're going to be worried about that. You're going to be looking at loss of lean body mass. Are they starting to look gaunt? Do they have a loss of energy? Because again, remember, they are losing muscle, okay? We, of course, look at the CD4 count, the viral load, adherence to ART. The goal is we want at least 95%. Obviously, we would love to aim for 100%, but they're trying to be realistic, right? We're going to want to screen for TB because it's an opportunistic infection. Immunization status, depression, psychosocial. You cannot possibly underestimate the psychosocial aspect of this disease. Actions, universal precautions. This is not spread by contact, right? We're not gowning and gloving. This person is not on isolation. This is a blood-borne pathogen, and so universal precautions, right? ART as prescribed, talked about that. Nutritionally dense meals. We want to make sure that they're not losing weight. And we would be worried about anorexia small a, so they're not hungry. Nausea or vomiting, because that can lead to dehydration, weight loss, electrolyte imbalances, anything like that that throws the body off is a risk. We want to talk about emotional support. These people may be worried about dying, right? Progression to AIDS, and AIDS is not pretty. It is a sad, sad death. So, that, again, psychosocial, social services, maybe, support groups, anything like that. Teaching, avoid high-risk behaviors. Consistent use of condoms, absolutely. Adherence to the treatment regimens, infection control precautions at home, right? Again, no cat, toxoplasmosis. Let's not do that. No lizards and stuff, right? Because of the salmonella. If there is a blood spill, clean the blood spill with bleach. Simple, right? 1 to 10, normal solution. We're also going to have them do that bacterial-free diet, which is the raw or undercooked eggs, meat, poultry, fish, the veggies, all of that, those dirty veggies. Just avoid that. And then, of course, what signs and symptoms, which we had the slide about, when to report to a physician. Okay, so definitely look at that slide. Health maintenance needs. We talked about all of that. We talked about screening. So just be aware of all of that stuff. All right. Again, you do not have to memorize, the immune system dysfunction cascade that occurs, but be aware of it. Okay. Just be aware of how that happens. All right. That was module 4. 2 hours.